Hey folks, I'm Scott Weingart, and this is the EMCrit podcast. Today on the podcast, we're going to discuss a brand new sepsis trial that's going to get a lot of airtime on the various social media outlets and the various discussions. And I think it's very important to understand this trial. So today, I'm going to just walk you through the whole trial. And then early next week, I will be speaking to two of the lead investigators. So we will be able to get even more information. We will be able to delve deep. So this is the primer. Next week is the explosion. The paper we're going to be discussing is the Andromeda-Shock-2 RCT, which just was published a day ago. And it is personalized hemodynamic resuscitation targeting cap refill time in early septic shock, published in the JAMA. So we will dive right in just a second. Before that, a quick mention. Hey folks, super quick plug for the Awake and Aware conference that I'm putting on with a bunch of my buddies in Scottsdale, Arizona, March 2026. This conference is going to be amazing. It's going to create a bubble. It's going to be a retreat. It is so good from everything we've done in the past and everything we have planned for the future. You should come if you're burnt out, if you want to feel more joy in your life, if you want to just hang out for 3 days with an amazing group of people and chill and eat dinner and drink wine and enjoy life. Just go to the conference site if you're even mildly interested and check it out. See what you think. You could just go to Awake Aware Conference, all one word, awakeawareconference.com. That address again, awakeawareconference.com. Please just go check it out. You don't have to sign up. Just go look, see if it piques your interest. All right, let's get to the show. All right, let's get into it. So Andromeda-Shock-2, let's do a PICO. So the patients included in this trial were adults with septic shock. So they had septic shock as defined by a suspected or confirmed infection. They had elevated lactate greater than or equal to 2, and they were on norepinephrine to maintain a MAP of 65 after an initial fluid load of 1,000 mLs. So that's a very legitimate entry criteria for septic shock. And they could be identified at any point in the hospital, whether it be the ICU, the ED, the operating room, or the inpatient floors. Patients could be recruited up to 4 hours after they met those inclusion criteria. They wound up, after all of the wherewithal, with 720 patients in the intervention group and 747 in the usual care group. And to get those numbers, they had 86 sites in 19 countries. So this is not a single center RCT. This is an 86 center RCT. What was the intervention? It was a rather complex bundle of therapies, which we will go through in intimate detail. So it was a personalized hemodynamic resuscitation protocol targeting the normalization of cap refill time. And this was building on the work done in the original Andromeda-Shock trial. There were multiple bedside assessments, and as mentioned, I will go through each and every one of them in just a few minutes. The comparison group was pragmatic. It was usual care. So they could pretty much do whatever they wanted according to their local or international guidelines. And they only had mandated cap refill time at time 0 at randomization and at the end of the study period, the end of the study intervention period, which was the 6-hour mark. So this was a 6-hour trial. The usual care group got whatever they want, except they had a CRT at the beginning and the end that wasn't used for clinical care. The intervention group had continuous care to optimize that CRT throughout those 6 hours. The outcome, this is where it got a little bit complex. Now, the complexity was to good purpose, and that's what the authors would have you believe, and I'm sure there is legitimate rationale for what they were doing. It is just beyond my capabilities to assess. I will leave that to my betters. Maybe Ken Milne will discuss this, because this is a trial design I have not seen. It is a composite endpoint, but it's a hierarchical composite. So instead of just bundling together 3 endpoints into a composite endpoint where, you always worry that the ones we really care about, the patient-important ones, get washed out by the ones we don't. This was an attempt to alleviate that issue. So the 3 portions of the endpoint were 28-day mortality, very legitimate patient-important outcome, duration of vital support, which was freedom from vasoactives, mechanical ventilation, or renal replacement therapy. And then the last one was length of hospital stay. So those were the 3, but those were actually ranked. So mortality was considered most important. And then only if the mortality was the same in the comparisons, then they would look at duration of vital support. And then only if that was the same, they would look at length of hospital stay. So they really are weighting the patient important ones, mortality definitely. That duration of vital support, that seems pretty patient important to me as well. And then the length of hospital stay, not quite as important as the other two, but that's good because it's lower down. Now, the other thing that got a little bit different than what I've seen is that this was a win ratio analysis. So essentially what they did is they compared every patient in the intervention group to a bunch of the patients in the standard care group, and they would then compare to see which group did better on mortality. Okay, if they did the same, which group did better on duration of, which of each of these individual comparisons of each of the patients in the intervention group with multiple different patients in the usual care group, which in each of those head-to-head battles, which won, the intervention group or the usual care group, or did they tie? If they tied, then they'd go down to the next one on the hierarchical composite endpoint. Does that make sense? So first they'd look at mortality between each comparison. And then if both patients were alive, then they would look at duration of vital support. And if the patients had the same, then they'd look at length of hospital stay. So they were really weighting the ones we care about. And now, even further, it was a stratified hierarchical win ratio analysis, meaning that they split patients up by Apache score and a number of other variables. And I'm sure there's some additional statistical intricacies that when we speak with the authors next week, we will go into. All right, how the patients look at the baseline. This was a sick group. No one could argue that these patients weren't sick, which is good. That's what I want to see in a trial like this. As already mentioned, all the patients were on norepinephrine. Almost half of the patients in both groups were on invasive mechanical ventilation. In terms of fluid prior to randomization, the median was 1,500 cc's. So these patients weren't drowned prior to entry into the trial, which was thereabouts 20 mLs per kg prior to trial entry. Their lactates were high. So let's see, around 3.6, 3.7 was the median for lactate, and almost half of the patients had lactates greater than 4. So like I keep saying, a sick patient group. In terms of at baseline, who had cap refill times greater than 3 seconds, it was 58% in the intervention group and 61% in the standard care group. All right, so what were the goals of the intervention group? They wanted to normalize CRT, cap refill time, and they wanted to do that by identifying whether it was a pipes, pump, or fluid issue, and they wanted to do it in as simple a way as possible. So you'll see there's 2 tiers. The first tier, you don't even need to bring an ultrasound to the bedside necessarily. The second tier, you do basic things we're all doing in intensive care. And they wanted to make sure that no fluids were given without an assessment of fluid responsiveness to make sure these patients weren't being drowned in excess fluids that were unnecessary. And then they wanted to optimize all the vasoactive parameters that they could to normalize that cap refill time. As mentioned, a 6-hour protocol. They monitored the CRT at baseline, the cap refill time at baseline, and then every hour afterwards if the patients were doing well. If they were receiving interventions, then they'd have their cap refill time checked after each of those interventions. In the usual care group, they just had their CRT mandated to be monitored to be checked at 0 and 6 hours, though the people in the usual care group could get their CRT checked as much as they want based on clinician discretion. They could also have echoes done. All the other hemodynamic tests were as per their clinical judgment. Now, during that 6-hour study period, 85.9% of the patients in the intervention group normalized their cap refill time, compared to 61% in the usual care group. And in that intervention group, only 35%, about a third of the patients had to advance to tier 2, which, as I keep saying, I'll explain momentarily, but tier 2 was the more involved, convoluted things you had to assess for versus the real easy things. So only a third of the patients had to go to tier 2. All right, so there's a very nice diagram that goes through the personalized hemodynamic resuscitation protocol that is in the show notes for this episode, EMCrit.org/411. But I'm going to walk you through each one, but it does make a lot of sense if you just quickly glance at that. So if you are not driving a car, you might just want to pause, go to the show notes, take a look, and then come back to listening because it'll make a lot of sense. But I'm going to go through it step by step. All right, so first up, none of this is being done unless they have an abnormal cap refill time. So only those patients are getting all of these hemodynamic optimizations. So then it begs the question, how do you monitor their cap refill time? So this is the same way they did in Andromeda-Shock. For the study, and this is just to make everything as even as possible between all of the sites, I imagine. So they're applying firm pressure to the ventral surface. That's the fingertip, not the fingernail side. The fingertip side of a distal phalanx of an index finger using a glass microscope slide. And the reason they're doing that is it allows you to see the skin blanching through the side. And they increase the pressure until the skin was blank. All blood knocked out of it. They maintain that for 10 seconds, then they release it. And then with a stopwatch, they monitor the time it took to return to normal skin color. If it was longer than 3 seconds, that was abnormal. If it was 3 seconds or less, then that was considered normal. So 3 seconds is your break point. Now, when I had seen the Andromeda-Shock-1 trial and started doing this on my patients, I did not use a glass microscope slide. I would just squeeze the finger really hard for 10 seconds and then let go. And I probably should have actually used the stopwatch. We'll talk about that with the authors, but I would just use Mississippi's. I'm sure in Chile and other parts of the world, they have a different word they use to time those 3 seconds. But in America, for most of us, it's Mississippi. All right, so that's monitoring the cap refill time. So tier 1, if you had an abnormal cap refill time, was to look and see if the pulse pressure was greater than or equal to 40 millimeters of mercury. And if it was greater than or equal to 40, then the assumption was at this stage of the game that inotropy was okay because that pulse pressure is a surrogate for your stroke volume. If it was greater than or equal to 40 of your pulse pressure, then you looked at your diastolic BP. And if your diastolic blood pressure was less than 50, then you would up the norepi that the patient was already on to get a diastolic blood pressure greater than 50, with the rationale being that even though their MAP may be 65, the diastolic blood pressure may be too low to perfectly perfuse the heart. So you'd knock that up, and then you'd recheck the CRT. If the CRT normalized, then you'd leave them at this elevated norepi dose to keep that diastolic blood pressure greater than 50. If it didn't normalize the CRT, then you'd go back to your original MAP of 65 blood pressure goals and reduce the norepi dose back to where you were. All right, now, if their pulse pressure was less than 40, or you had tried that diastolic blood pressure push and it didn't work, then you move on to fluid responsiveness. So for fluid responsiveness, you're going to assess it, and I'll mention in just a second how to do that. If they were fluid responsive by your assessment, you'd give 500 mLs of crystalloid or 5% albumin over 30 minutes and then reassess the cap refill time. If it was still abnormal, at this stage in tier 1, you could repeat that fluid bolus times 1. So in tier 1, they're getting a maximum extra fluid of 1,000 mLs. And for that second one, you had to check again, are they fluid responsiveness? So let's talk about the fluid responsiveness methods. So the ones that were considered really good were passive leg raise with monitoring of the stroke volume or cardiac output, end expiratory occlusion tests in patients who were mechanically ventilated, pulse pressure variation or stroke volume variation when the patient had the right conditions for it. And I'm not going to go through those. I talked about them numerous times on the show. Or the echocardiographic surrogates, so a increase in your LVOT, VTI during passive leg raise or mini fluid challenge. And now they have here, and I'm going to ask them about this, the IVC, both collapsibility or distensibility. Now, collapsibility would be for a spontaneously breathing patient, distensibility for a mechanically ventilated one. The latter, the distensibility, that's pretty good. Collapsibility, we're not as happy about. I'm glad it's here because I think it is an adequate marker of fluid tolerance, which is probably, if just as a sneak peek, is probably how I'm going to be adopting Andromeda-Shock-2 to my practice. is the consideration of that 500 or 1,000 cc of fluid if they're fluid tolerant and their CRT is not good. But I'm probably not going to be doing fluid responsiveness checks, except for the one that they don't like as much, which I'll mention in just a sec. But collapsibility is not really a great marker